Welcome everyone to this session of DiGo Talks. I am Dr. Divyam Goswami, and I am with my dear friend and colleague, Dr. Bhavya Bansali, organizing this session of DiGo Talks on internal family systems therapy. And we have with us Dr. Sam. Dr. Sameh Younan is a fellow of Royal Australian and New Zealand College of Psychiatrists, a psychiatrist and psychotherapist based out of Sydney, Australia, and he'll be talking on internal family systems therapy. Welcome, Dr. Sam.
Welcome. Thanks so much for having me.
Yeah. So, first of all, I would like to ask you that how did you get into this internal family systems therapy? And then we can maybe start uh, discussing about the internal family systems therapy.
Yeah, well, that's a great question. I should put a bit of background. As a psychiatrist, I always had this interest in therapy. When I first did my child adolescent training, I saw these journals, family therapy and things, and I thought I really should read more about, get an idea of therapy. And I read a book and it explained it had like 10 or 15 different types of therapy, and one of them was internal family systems therapy. And to be honest, I read that chapter, didn't really resonate. I kind of left it there, I didn't think much of it. Then throughout my therapeutic process, I came across different types of therapy. My first real passion was family therapy, because I kind of felt with family therapy, there's this way of addressing problems that individual therapy can't. And this sort of idea that problems are systemic in nature, if you can change a system, you can change the symptom in a person. So for example, let's use the example of someone who's anxious. In theory, if you can have the parent set more structure and in tune to the anxiety, then you can reduce, the feel of anxiety and the person can progress. So I kind of had this idea, you really need a system, to be able to change individual symptoms. That was kind of the first the milestone along the road to IFS. The second was this course I did in something called Team CBT. Now, most of us are familiar with CBT. So, for example, have anxiety or depression, the idea is use the thinking behaviors to reduce the feeling of anxiety or depression. But I went to this guy, had this is David Burns, who's written a book called Feeling Good, which is quite well, quite popular. And he had this interesting variation on it. And he gave this example of this woman, she was actually a psychologist, but she talks about this example where she let her children go outside and, one of those children got, hit by a BB gun and she was jaw surgery and she felt depressed. She felt terrible about herself. So in his manner of dealing with her, he had this key question to her, which was that if I could reduce your depression to 0, would you accept it? She goes, of course. But he goes, hey, wait a minute. What positive things does your depression say about you? And one of the things, well, actually, if I wasn't depressed, I wouldn't be a very caring mother. So yeah, okay. So then he said, well, do you actually want to lose your depression? Because it seems like it's serving a function. If you lost your depression, wouldn't that mean you're not caring anymore? So it actually had this interesting spotlight that it's actually a useful function for these symptoms that, were things that we call symptoms. And that, again, that was another milestone along the way to IFS. The third milestone was a particular type of therapy called DDP, Dialectic Developmental Psychotherapy, which focused on a tuning between the parent and the child. When you have a very strong emotional experience and someone is able to empathize, validate, and attune to it, that can actually change your experience of emotion. So I kind of came to this idea again that, with attunement, you can modify the emotional experience. Another milestone, I guess, was EMDR, because before EMDR, I thought if you have a negative emotion, you can't really do much about it. You can either reduce it with your thinking, or you can just accept it like an act, but you can't actually change it. But EMDR actually, no, you can actually process that experience and change your experience of it so that negative emotion goes away. And I guess along the fifth aspect was internal family systems. And I must have, I think one of my colleagues mentioned it and I saw a book about it, but I read it deeply. And there it kind of brought all those previous ideas together into kind of a neat package that resonated for me.
Great. So this is the fifth therapy or the fifth milestone in your career as a psychotherapist, isn't it?
That's right. Yes, yes. Like, and there might be sort of other things along the way, but I guess in terms of the moments that I had like key revelations or key insights, they really brought to come together.
Yeah. And uh, were you fascinated by internal family systems therapy, and that's the reason why you switched over to internal family systems therapy? Or uh, do you think that the earlier therapies that you practiced, you had some kind of dissatisfaction with them?
Yeah, that's a really good question. And I think one of the things is that when I first came across internal family systems, as I mentioned in that book, 12 years before, it didn't resonate. So maybe there was something along the journey of these different types of therapies that kind of, caused some change in me that made me more open to the idea. I think I came across it where, yeah, to be honest, I think before I came IFS, I kind of felt, oh yeah, pretty kind of comfortable as a therapist. I think, to be honest, actually up till the IFS, I think most of my interest was family systems. I'd kind of written off individual therapy altogether, I think, from memory. And then I thought I should learn more about IFS. And as I came across it and read the book, and then actually trialed at some adolescents that I had, and I was really quite amazed that as I was trialing it, they actually responded really like along the lines I've read in the book. It's as if they'd read the same book, but they were giving these answers. Yeah, that's exactly what's saying in the book. But to an outside observer, the questions would be very obscure and the answers would be very strange. And yet these adolescents were responding to them. And actually, and some that actually had very difficult, where the treatment was actually quite challenging, they're actually giving quite positive responses. And that gave me a real sense that there's some sort of sense of validity about this therapy.
Yeah, so you're trying to say that the response rate was better with internal family systems therapy than the kind of therapies that you have practiced earlier.
Yes, yes.
Great.
Mm.
Now, to start with, for somebody who doesn't have any information or any knowledge about internal family system therapy, how would you introduce internal family systems therapist with some background knowledge of psychiatry, but absolutely no knowledge of IFS?
Yeah, so that's a really good question. And maybe I can broaden it to talk about starting at the core. A lot of what we do in psychiatry is about negative emotional experiences. For example, anxiety, depression, trauma, even psychosis. There's a lot of negative emotional experiences about those things. And that's really the key question. How do we deal with these negative emotional experiences? They come in all sorts of settings. For example, you might have somebody who says something to you and it doesn't sit well. And someone else might say, don't worry about it, but like it just doesn't sit well. We have a parent of a child and the child's doing something which is getting the parent dysregulated. And you might tell the parent, look, you've got to stay present, you got to not react. But the parent still has that distressing experience. Or you might have someone, for example, who's anxious about a particular situation. You can reduce it by thought challenging exposure, but it doesn't always necessarily always go away. And some things are particularly difficult, for example, like OCD. Or someone with anorexia, there's this emotion driving them to reduce their weight. There's often this emotional experience with it. And when we sort of dealt with psychiatry, it's often been at the level where you kind of try to work around the experience. You don't sort of really delve into it. So, feeling bad, okay, medication, therapy. We don't really tend to delve into the emotion deeply itself. So I guess the first point I'd like to make is IFS is a way of addressing these emotional experiences, which are felt in the body, and which we don't necessarily deal with. The second type, I'll give you an example. Say, for example, you talking to your boss, and you might feel he said something like which kind of didn't sit well. Maybe he wanted you to stay back overtime or something like that. You might have a part of you that's compliant. You go, okay, do what you said. Yep, no problem. Another part of you that's angry. Why does he do that? It's so annoying. So that same situation triggers two different parts. Both parts are actually, they're polarized, but you kind of end up sort of making a decision based on, whatever situation you are. In IFS, the idea is to understand these different parts of us. And there's more than just two parts. There's actually many parts, and they develop all throughout life. So, for example, let's say you have a child he gets distressed because his parents are away. So he develops this part that's feeling quite lonely, and that's not a pleasant part. So he tries not to think about that part, tries to move it to the side, and that becomes what's called an exile part because unpleasant emotion doesn't like it. Or a child, for example, gets ashamed for failing. That part that's carrying the feeling of shame moves it to the side. Then as they grow, develop, they'll learn to deal with other parts develop to help protect those exiled parts. So, for example, a part that becomes quite clingy to the parent or knows how to draw the parent's attention. Or a part that becomes quite proficient at school because they know when they do that, then it takes away feeling of shame. So they develop these kind of protective parts, which help prevent from the exile, what I call managerial parts. But then sometimes even those strategies don't work, and the exile feeling becomes overwhelming. And so they develop the third category of parts, which are called firefighter parts, which do whatever they can to deal with those extreme emotions. And that can be, on one side, it can be dissociation, numbing, and can be rages of anger to try to deal with the really deep negative parts. Or it can be things like, for example, drinking or substance use or self-harm. So these three categories of parts that we develop. And in IFS, there's this concept that apart from the parts, you have this concept of self, which is kind of like the soul as a Christian, I believe, which is compassionate, considerate, courageous, confident. And that self is able to communicate with the different parts. So this is where it gets really spinny and weird. But as yourself, if you ask the client to feel, for example, that part of them that feels anxious, where do you feel the anxiety in your body? How do you feel towards that part? And you can actually ask the part, how is it trying to help you? And this is what gets really trippy and weird, is that they actually hear a thought from that part. It'll often say, I'm trying to protect you. And you actually get responses. And then by actually having conversations with these parts, you actually befriend the parts and they start to settle down. And as the parts settle down, they have more of this self-energy that emerges.
Yeah. So, I had discussed this with you on the phone call that we had, that despite of the name family, it's an individual therapy, isn't it?
That's right, yes. So these different parts exist in the same system. So that's the internal system. You have like the managerial parts, which are designed to protect the exiles. You have the exiles and you have the firefight. They kind of exist in this constellation.
Yeah.
And very often, I should say, just like in a family, you have sequences. So one of the big ideas from family therapy, this idea of sequences where, just to give an example from a family, you have a situation where, classic one, for example, is that the child is feeling isolated, the child becomes disruptive, the mother tries to settle down the child, the parent, okay, let's say okay, sorry, now start again, sorry. The child feels disconnected from the father, for example. So the child becomes disruptive, the mother tries to settle the child down, the mother can't settle down on their own, the mother calls the father gets involved, the father speaks to the child settles, the father goes back and does their own thing, and so the cycle repeats again. So one of the concepts that family therapists brought us is this idea of sequences. That is actually, even though the outside behaviors change, but the same sequences happen over and over. And these sequences happen both in systems and in an individual level. So if you track it, you'll find that it's actually typically the same sequences or the same parts are, are triggered in the same sequence, which keeps recurring over and over.
That's amazing. I mean, I was surprised and amazed at the same time at the concept of internal family systems therapy. Uh, can you please tell us about the history of internal family systems therapy, how it originated, and how is it faring in the world right now?
Yeah, it actually started in the 80s by pretty sure the psychologist in Harvard. He actually started as a family therapist, David Richards Ford, Ditchfords, and he started his career as a family therapist. And he sort of makes these kind of jokes that he sort of like he learned that family therapy was the key to everything. But then when he worked with some fame, and the idea is if you treat the family, then the symptom goes away. And he kind of jokes saying, well, some families didn't read the book. They should have, they didn't respond, they should have. And he gave this example of doing a therapy with a patient with bulimia. And she had this part that wanted to, keep binging, purging, something like that. And he kept on having really this part of her, kept on arguing with that part. And we kind of do that a bit like anorexia, for example. We sort of externalize the anorexia and you start to go, no, no, stop making it bulimic. And eventually, after a long discussion, she agreed. But the next week, he saw her, so yeah, she had scars on her face. So she'd actually cut her across the face. And so basically, that was like a key moment for him. But essentially, he realized that there's different parts. So there's a part of her that wants to be bulimic, wants to be. There's another part of her that doesn't like the bulimia. And then these other kind of feelings of shame that both parts are covering. And he eventually found that as he sort of got, that listening to patients that they say something like, oh, this part of me wants me to binge. I don't want to, but this part of me wants to binge. And so he started using his kind of training from family therapy because in family therapy, there's that idea of the symptom bearer. So, for example, if a family comes in, they present a child who's got disruptive behavior, that child is actually the flag bearer for the system. And what he's saying, there's some other problem in the system. For example, that there's not enough attention going to the system, or the parents aren't aligned together, or that, the parents are busy looking after the older kid who's got developmental disability, and the younger child's not getting, the achievement they need. So when that child presents, it brings the system to attention, but it's not just with that person individually, it's with the whole thing. And the theory is if you spoke to the child and ask them what's wrong, if you're able to, help them explain what's going on, why they're acting out to the rest of the family, then when the rest of the family hears that information, then they start to modify their behaviors. So he applied these same principles to the internal model. So if there's anorexia, for example, the part doesn't want to eat, rather than just trying to get rid of that part, in the same way that you wouldn't get rid of a child who was just behaving, he was acting out, is to have a conversation, befriend that part, understand what the function of that part is. And it might, for example, a part that's bulimic, it might be saying, well, if when I binge eat, it numbs out this very deeper, unpleasant, uncomfortable feeling. So when it's understood to have that part, and when the self actually shows appreciation to that part for the effort that it's doing, and offers if it's a different job it would like to do it, that it would do, that part starts to relax. And then that seems to sort of lend into the, on a neurochemical basis, I think, as in memory reconsolidation, which we might be talking about later, that which causes change in the client. Oh yeah, so we're IFS at the moment. So that was I segued a bit. That was his discovery. So now IFS, it's quite widespread at the moment. In like it's a bit of the flavor of the month. There is like if you go into popular bookshops in Australia, for example, like not specifically medical books, whatever, just public books, you'll see books about it by Dick Schwartz. There is quite a lot of therapies, but the therapy is quite intense. I'm doing the level 1 training in May God willing. It's going to be, I think, 11 days in total, just for level 1. And there's 3 levels. So there is an intensive level, and there are people who sort of look for IFS specialists particularly. Most of the psychologists have heard of it, where I work in Australia. Most of the psychiatrists probably haven't. But, I think slowly they are becoming more aware.
Yeah, so it's gaining traction there in Australia.
Yeah, I believe so. Yeah. Mm. but not everywhere. Like, for example, I know we have this conference and it's called the Childhood Trauma Conference in Melbourne. And, there were no speakers from that speaking about the childhood trauma model there. Like, I think I saw a couple of books in the book, in the bookstores. So there's sort of it's kind of still big gaps where it's not really well known.
Yeah. So you mentioned about one of the milestones in your psychotherapy journey where you were practicing DDP. And
Yes.
so, can you tell us something about DDP and how it differs from internal family systems therapy, and how did you switch over to internal family systems therapy from DDP?
Yeah. So basically DDP is a family therapy, like an external family as opposed to internal family. And the D in DDP stands for dyadic. So dyadic is between two people. And the other D is developmental psychotherapy. And it's all about focus very much on attachment theory. So systemic family system was kind of more about sort of general function of the family, tracking sequences. But from DDP model, and there's other attachment-based sort of family therapies, but he was saying like the key of all of this, the key need that the child has when they're being disruptive or being depressed or being anxious is they're needing emotional attunement. And what do I mean by emotional attunement? Let's say, for example, you did something you were so ashamed of, it was so horrible, you didn't want to tell anyone about it. And then you actually tell somebody. And then that person, instead of judging you, they actually listen to you and they actually respond with empathy and compassion rather than, critical behavior. That changes your emotional experience of it. But to get there, you have to be open to really going to very deep emotions. And for children, it's often things like at the core of it, like for example, the external behavior might be, say, like acting out, and you ask, it's a particular type of questioning which helps get to the deeper core emotions of the child behind the acting out. So you might ask something like, what are you worried would happen if, why do you act out? What's the only way to get them, my parents' attention? And, what are you worried might happen if you don't get their, why do you think they're not giving you attention? Well, I think maybe they don't really, like me as much. What makes you think that? Well, they always spending much time with my older brother, and they always seem to praise him when he does well, and they don't praise me. And what does it make you think about yourself when they don't praise? It makes you feel I'm pretty bad. It makes you think I'm pretty dumb. Oh my goodness, that sounds horrible. All this time you carrying this feeling of, feeling dumb, and your parents are doing all this thing. They're busy spending all this time, and you just see them busy all the time and they're separate from you, just keeps you leaving you isolated and alone. What a tough feeling to get this. And when you get to the child to say something like that, you ask the parent, did you know they were feeling this way? No, what's it like for you to hear this? Like, it feels very sad to hear. They had no idea it was causing distress. And they say something like, I'm so sorry I've been giving this experience. I need to do a better job of showing love because it's so hard for you to carrying this feeling and mind for so long. I've kind of nutshelled it. Like it takes a lot of preparation. Not all families get there. But the idea is to get there by working individually with the parent, then the child, and bringing them together to have conversations like this. But because there's something about the specific nature of these questions which are quite deep and profound, and they get the child to say things which they may never have said to it before. They're using, I guess, from IFS language, they're accessing their exiled emotions, and they're sort of getting an attuned response from the parent. And from a neurological basis, there's actually something about this empathy releases um, oxytocin and causes memory reconsolidation, and it gives a new emotional, and there's a new emotional experience that comes out of it. Um, or this sort of rewiring or a corrective emotional experience is the term. So as a child psychiatrist, I tried to do this quite a bit because we're coming from a place, it was acute hospital service. It was sort of the community clinic, a lot of, presentation with suicidality, and the key question when suicidal parents, kids is why didn't you tell your parent what stopped you in the way telling your parent you were suicidal? Often they have an overdose, haven't told them what stopped you. And people will say, if you had appendicitis, would you tell your parents? Probably, but okay, why wouldn't you tell them if you're suicidal? So whatever the reason they haven't is there's something about the previous experience of these type of conversations where it doesn't go well. Either the parents have been dismissive, or they've been sort of too problem solving, or the parents have been panicky. And so because of that, and that it's both contributed to that way they're feeling and stops them from getting help. So what I really focus on, if you can change the nature of this communication, you can change the child's experience or their attachment relationship with their parent and get attunement with way. So I do believe the family therapy is actually helpful quite a lot. Not for necessarily for everyone, but at least for a certain number of families, that I worked with in different settings. And, there are various problems along the way, but, some of them, had a negative experience, but, at least a proportion of them did. But anyway, I came sort of quite convinced along that way. And I just point out as well, whilst I applied it to suicidal adolescents in hospital systems, and informed by other systems like ABFT, attachment-based family therapy, is kind of similar. It originally was devised for kids in out-of-home care in England. Well, not necessarily England, it's adopted largely in England, where training foster parents how to communicate with their children and what sort of typical patterns work, and how they kind of need like as another person calls it, kind of like a super attuned way of communicating with them. Like the normal way might work well with their, normal kids, not normal, sorry, normal, but like their kids who are not, who are born normally to them. But with kids who experience trauma, you need this sort of super attuned way of communicating with them. And Dan Hughes, he's a psychologist, he lives in Maine, and he developed it, and he actually said that he learned how to he just used the way when he was working with the typical model as a psychotherapist, where you were a blank face, you weren't in tune with the kids. It didn't really go very well. But then he started talking to them the way he talked to his own grandkids. And he found they actually responded quite positively. So he took the model, and DDP's really taken off in the UK. It's quite well known there. I don't think it's quite had as much momentum in the rest of the world, unfortunately. I know they're trying to promote it there, but anyway, that was a big thing, part of my work. I was using it, still right up to the end of my private practice, but um, as I moved to private practice, I found it actually very hard to get families of family therapy as a psychiatrist in Australia. So I thought, I don't want to do medication really, so I want an individual model. So which is kind of that's helped shift my emphasis to IFS. But I guess IFS can work in individual, but it can also work with, I can apply it to the dyadic setting as well. So for example, I bring the example of the parent who, it's all very well just try to ask the parent to attune to their child, but the parent themselves will typically have parts of themselves where the child behavior triggers them. So for example, if the child is suicidal, that might trigger a part of them that's very panicked, or a part of them that wants to dismiss the child's emotions. And so IFS provides a context where you can speak to the parts, help the client to speak to their own parts, and then that way they can settle down their own emotional experience. And then they're in a better place to release more self-energy and better attune to the child's needs. And that was, I have applied it, with a couple of, particular family I can think of. And, that seemed to be some benefit in that, where you sort of work IFS with the parents and then the kids. Kind of limited success otherwise, but I guess I haven't had many opportunities really to really integrate the two together, but I can see how they could be integrated that way.
Yeah. So the next question will be asked by my colleague, Dr.
Yeah.
Bhavya.
Hello.
Hello. Yes, doctor. So earlier you mentioned about the different parts of the internal
Yes.
system, such as the exile part, the self part, the firefighter, and the managers. So
Yes.
I wanted to ask, is it so that these parts are often blended into each other? And so that to move forward with the therapy, how does the unblending of these parts occur?
Yeah, that's great. So look, when they talk about blending, they kind of mean when the self is blended with a particular part. So for example, if someone's acutely angry, then they've become blended with that angry part. It might be for that moment. People can be blended with the parts for longer periods of time. So, for example, if you've got someone who's very very managerial, very bossy at work, for example, very driven, that they're kind of driven with they blend with a very driven part. So I guess the blending, so the unblending, which is a great question, how do you take it away? I'll use the example of maybe it's say an angry part that might feel this feeling of anger, and first you kind of work out how angry they, how close, how blended they ask, and how close. You ask how close does that part feel to you right now? Like I was very, very close. Some things are easy. You can ask, can you ask that part if it's willing to step back from you? And sometimes it is. And then what's it like to step away? Sometimes it's harder. When it's like, can you breathe into that part? Can you let that part know you can hear it? Can you, acknowledge? Can you let the part, you're glad it's here? Now, can you ask if it's willing to give you half a centimeter of space? Sometimes you can use other techniques like, crayons. You say, can you draw out the energy of that part on paper? And as they draw it out, then they look at it, oh yeah, they can see it's different. Or sand tray, there's something called virtual sand tray online, which is a free website, but they've got these different clip art pictures on the side and like an image of a sand tray, and you drag the figures and put them on the sand tray. Can you pick the party that looks angry? Can the part that represents you? And when they see it separately there, that helps create distance. And there's a technique as well called direct access, where you talk directly. Can you just let the anger speak directly for you? Okay, why are you so angry? How are you trying to help such and such by being angry? And as I answer directly for that question, that causes some unblending. So I guess in answer to the question, there's kind of specific techniques that are used for that, as I gave examples of.
Yeah, that's great. So, by the process of unblending, they are also unburdening themselves, the patients.
Yeah, so the unburdening with the terminology, like within the ordinary use of the term, yeah, they are unblending. Now, unburdening, sorry. Now, within IFS language, there is a very specific meaning of unblending, and that refers back to the time when their exiles first carried these unpleasant feelings. So for the first time they can remember, when they first felt shame, for example, they felt humiliated or embarrassed, these very sort of core negative feelings. And they use a technique which is visual rescripting. I'm not sure how well that's known, or imagery scripting, and it's kind of modified, but it's like that technique's kind of used all over the place. Like it's used in schema therapy and I can't emotional focus therapy and things like that. But basically, what happens is that that they come back as an adult and see the younger version of themselves carrying this child, and then they provide a different emotion. They imagine themselves giving their younger selves a different emotional experience than what they had. And that actually changes the emotion.
Yes.
And then the unburdening is they give them a choice. Would you like to does the child have any other unpleasant feelings? Would they like to get rid of those feelings? And then the unburdening often like put them into water, fire, whatever, and replace it with positive feelings. So
Yes.
yeah, the terminology just a bit more specific in IFS language.
Yes. So what I get from your answer is that it would be something like assigning these managers a healthier role, the role that they
Exactly.
are. Yes.
Exactly, yes. And often it's very interesting. The managers, you often ask them what would they like to, and often it's something completely different, the exact opposite. So, for example, a manager might say that might highly driven, and you'll ask something like to the manager, what are you worried will happen if you stop doing your job? Well, that, Nader or whatever will be left alone. And then you ask if there was some way we could guarantee, just hypothetically, some way we can guarantee Nader wouldn't be left alone. Is there a different job you'd like to do instead? Yeah, often that sounds like, yeah, I'd like to have fun. I'll go on a vacation. Sometimes they might give something, yeah, like I still like to do my job, but not as intense, for example, but often it's the opposite. But exactly. So assigning them healthier roles for the system. Yes.
That's great. I also wanted to ask, earlier you mentioned regarding the attachment theory. So,
Yes.
does the various type of attachment affect the type of managers or the firefighters as well?
Yeah, that's another really good question. So attachment theory, um, yeah. Yeah, so there's different ways of looking at it. I know, for example, some people like Frank Anderson, he's like a big IFS proponent, and he says something like each of the parts has a different attachment relationship with the self, as he puts it. From my perspective, I also came across the work of Pat Crittenden. I don't know if you've heard of her, but she's got this model called dynamic maturational model. And she's basically got sort of three broad clusters. One is cluster A, second is B and C. Cluster A is people who are more avoidant attachment. She doesn't use the term avoidant. She's compulsive, but people who are kind of driven, kind of to do what the environment demands of them. So they might sort of suppress their emotions. They might have like coy smiles. They might have compulsive performance, or then they might develop more other strategies of sort of compulsive you know social promiscuity, making lots of friends as a way to cover sort of more negative emotion. They're kind of driven by my logic, what I need to do, and they can suppress negative emotions. Cluster C is more kind of where there's an alternation. There's more emotional, like the cluster A will suppress negative emotion, but then have these intrusions of negative emotions and it's going to explode. Cluster C is where these, by nature, they're sort of more emotional. They can be more demanding, more coy, more sad, but they will fluctuate. And we see people like this. With the way they talk is very animated and goes up and down, and everything's like this. Everything was the most amazing thing ever, and this always happened ever. Whereas the cluster A is more speak more in a sort of into prosody, or like monotone and more factual. But the cluster C, the idea is that they have the alternate more anxiety, more anger, those sort of things, and going to different levels and those sort of things. So I suppose often when I have someone with IFS, I think, oh, that's interesting. That their parts kind of match more of this A pattern, or they
Yes.
match more of this C pattern. And it may be as well they develop certain parts, for certain situations, which kind of would fit a particular attachment style. But to be honest, often it's a mixture of parts of A, parts of C, kind of here and there mixed together. And to be honest, that was a big thing that I noticed
Yeah.
in practice. Often you'd have people very classically fit one or the other, but in reality, it was often a mixture of both sides, which kind of made me question the validity a bit of more sort of distinct attachment styles.
Yes. Thank you, Doctor. I had another question. You earlier mentioned regarding the memory consolidation. So,
Mm.
do these parts they have some correlation with the neuroanatomical substrates?
Yeah, it's a great question. I mean, I think that the parts is that it's a really good question because it lends its what are the parts? I mean, some people actually believe there are actually actual parts. I don't know what they mean, like whether the soul is broken up to different things or there's different parts of the brain. In my view, I think that the parts represent sort of different memory processes, memory programs in the brain. So, for example, if you ride a bicycle, this sequence of motor sequence gets activated. Your right leg pushes forward and the left leg gets activated in a particular sequence. If someone upsets you, someone says something, you have this sequence as well. You might have a part of you that says, you know what, who cares? I don't care. And then another part of you that starts to say, hang on, what they said wasn't right. That other part, no, argues back. Then a third part says, let's walk away. And then in the fourth part, this is let's complain about this person to that person.
Mm.
So what happens when someone says something, a sequence of different memory of different things is activated. There's different emotions, there's different thoughts, there's different motor processes, there's different sensations in the body. And that same sequence is repeated over and over. And I think they're encapsulated in a memory circuit that gets activated.
Yeah.
So that's my view of the past. So these particular memory circuits that are kind of generally left on their own, but when a particular situation happens, they're sort of triggered and they sort of, become activated and sort of take over. So that's my own personal conceptualization.
Yeah, great. So what I could make out from what you were telling is that the self would correlate to more like the prefrontal cortex, which is controlling or managing everything, whereas these managers or parts would act like the limbic system, which would correlate with the amygdala and with the hippocampus.
Look, that's a really good way of looking at it. I think I might say, though, that even with IFS language, even the executive functions like logic or reasoning, they'd probably be seen more like managers.
Yeah.
So in my view, like I'm a Christian, but like I see myself more as a soul, something that's kind of separate to all of that. Because even the logic ones isn't necessarily the self, because something's purely driven by logic
Right.
are not necessarily, doesn't quite align with the self. Like the self is compassionate, courageous, um, calm, clarity. Like Yeah, there's some overlap with executive, but it's probably more something when you have all those things in harmony rather than more being executive function.
Yeah. So it was amazing conversing with you, and we will move forward with Dr. Divya.
Thank you.
Yeah, so I had this question about the parts, and you discussed in detail about the parts. So, uh, do they have to do anything with the psychodynamic object relations theory of Melanie Klein, where the psychodynamics also talk about parts, the object representations and the self representations, which are internalized in childhood. So, is there anything to do with that?
Yeah, okay. Speaking about object relation, I'm just trying to think through. So you've got, I think so, that like, but it's not necessarily like a one-for-one correlation. But for example, like, if you have an internalized object representation of a like say of an authority figure or a relationship that the other object is harsh and critical, and then the self is and the self representation is a victim, for example, victimized. So in IFS, you have this concept that you might internalize this part that there's a part of you that an exile part that feels vulnerable and humiliated. And then there's another part that kind of is carrying that representation of the external critic, of the external harsh person, and that will be internalized as a critic part. So critic parts are types of managerial parts. So that that voice, so you didn't do a good job, around that critic that you have. So that would be kind of like as a polarized dyad that you have. I think from my sense, so there's obviously some, correlation there. And if you presented a case, IFS therapist would see it that way, the Kalanian person would see it that way. But I think something different IFS is this idea of the self as something that you're born with, that's actually comes with you, that's actually not damaged or doesn't need to be built up. Because my understanding from classic psychodynamic therapy, at least what IFS says about them, they might say I'm wrong altogether, but people have had severe trauma, they need their sense of self to be established or built up because they don't have it. They've just been so damaged and broken. But IFS actually know that people are born with it. They give these very self appropriate answers from, that they've got capacity for that from the beginning. But they just need the other parts to unblend it, and to settle. So I think that's what the key difference is. But they definitely, there's some things where you can see some correlation as well.
If I can check with you, how much more time do you have so we can?
I'm
I can.
right. Yeah. I'm free. Like I said, tomorrow's a public holiday, so yeah.
Yeah. So, following on that question, I think we also have one another therapy that I also practice, and that is the interpersonal therapy, where we sort of correct or we analyze and then restructure the communication between various persons or the interpersonal relations. So, is there any similarity between interpersonal therapy and internal family systems therapy? Because these parts are, you are managing the communication between these parts, you are managing the interpersonal relations between these parts.
Okay, interpersonal. Not is that IPT or is that different to that?
Yeah, that's
Oh,
IPT.
so the IPT that, for example, is there's four different. There's seen to be four different causes of depression:
Yeah,
global adjustment, grief, and two others I can't quite
yeah,
remember.
role transition and role dispute.
Yeah. Okay. All right. So I have looked at the therapy. It's been a while though. I did, but I'm just trying to recall what I said. I think, yeah. Look, when I did that therapy, like I did actually a little bit of training, I applied it to one or two patients. I was a very novice on my level, so I don't know if I did it properly. So or if I even understood it properly. But I think if I was going to apply it to that situation, um, I think it would be a bit different. And I think one of the modules, interpersonal effectiveness or something, I think, IPT, I think, or interpersonal dispute, that's right, interpersonal dispute, that's right. Yeah, yeah. I think it perhaps going at a bit of a different level, bit of a deeper level, which is to say, for example, when you have a dispute, what happens for you? What do you notice inside of you when you have a dispute? So, I feel really angry. Yeah, okay, you feel angry. Of course, it makes sense to make you feel angry. And do you notice anything else? Yeah, actually, I kind of feel a bit like ashamed, actually. Yeah, I said all these things about me, a bit embarrassing. Yeah, okay. Yeah, it makes sense. Anything else you feel? Yeah, I feel sad. We used to have a good relationship. We don't have it anymore. I've kind of lost that. Okay. So I guess from that perspective, you've got these different parts of figure. Similar with grief, don't you? Like with grief, we talked about the classic 5 Kubler-Ross stages of grief. But from my IFS, these are all different parts. Shock, numbness, anger, sadness, maybe acceptance is more of a self thing, but and they're not always necessarily one by one in the sequence where they all come about. So I think from IFS, you look at the different parts that are coming, and it might be something like, this anger. Where do you notice it in your body? Can you describe it? If it had a color, what color would it be? If it had a shape, texture, temperature, and then as they describe it, how do you feel towards it? Can you ask it how's it trying to do that? What job is it doing for you? So as you sort of befriend the different parts in that person, then that sort of experience goes settles and that more of their self energy frees up, perhaps to have those conversations. My recollection from IPT, it was more kind of a bit more focused on the skills. It's not very important. Not a lot of them have the skills, especially if you grew up and never socialized, you wouldn't know them. A lot of situations, just having the skills, having a conversation and giving them like a different outcome than what was anticipating, would lead to a corrective emotional experience, which is one of the theories behind memory consolidation and can be helpful that way. But I think it's a bit different in focus to what IFS is.
And how would a typical session of internal family systems therapy would look like? And how many sessions are there in a typical IFS?
Well, okay, I think it really, maybe I'll start with the first question. So what would a session look like? It'll be often like the first one be kind of like a review of what's happened, the previous week, da 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 da. And then they might bring up a situation which caused them distress. And they might, talk about it, maybe we'll use the example you gave there. Like I had an argument with my friend, oh yeah, what happened? Well, first, he said this, and first I was upset, and then I said, and I kept trying to keep it to myself, and then he said something else, and I got really lost and got angry. We've had a fight. And now I'm talking to him, and now I miss him. So I don't feel great about it. So then you kind of might track. I'm hearing a part of you was feeling quite hurt when he spoke to you. Another part of you was saying, "Don't say anything, just keep it quiet, quiet." A third part of you got really angry and lashed out, and the fourth part of you is feeling really ashamed by it, and the fifth part's really feeling sad about it. So you mentioned all these parts. Does any of these parts, would you like to interested in getting to know any of these parts? Any seem more interesting than the rest? Then they might say, yeah, the part that I got angry. So okay, with that anger, where do you notice it in your body? You feel, oh, I think it's my heart. Oh yeah, and it might be touching. Okay, if I had a color, what color would it be? I think it'd be red. And a shape, it's like shaped like my heart. And the temperature was very warm, very warm. Okay. And how do you feel towards that part of you? If they were to say something, I like it, I really, it's really, really is, that might mean they're blended. So you have to check. If they say, I don't like that part, I wish I would go away, then that means there's another part that doesn't like the angry part. So can you ask that part that doesn't like the angry part, if it's willing to step aside for the moment? And sometimes when it steps to something, I may immediately like feel something different. Not always, but often. So, I'm actually feeling curious about it. Can you let that part know you're curious about it? And then can you ask it about, okay, what job is it doing for you? It's trying to protect me. Okay. And you ask questions like, how old does it think you are or feel that you are? What does it want you to know? What does it want you to know about the way it's feeling? What does it need from you right now? And as these questions, it befriends that part's to settle. And I feel that's making a neurobiological process, making all these different new connections which weren't there before. And then you might ask something like, when did that part first um, start to do its job? Which is asking, for example, when it first came into your life. And it might be a childhood anger moment when they were feeling very sad, typically. And that might be an opportunity, what we talked about, for the adult self to come in, and speak to sort of the younger child, give nurturance to the younger child. The same as I talked about DDP before, attuning to the more vulnerable emotions. And when you see your younger self, how do you feel towards it? Now, as a bit of a segue, people are often have negative attitudes towards their more vulnerable parts. If you think about the things that kids bully themselves with for school, each other, they say, a mummy's boy. It might be that there's a younger part of themselves when it was seeking their mum's attention, didn't get it, it's feeling for hurt. So another part, so I don't need mum's attention. They see another child getting that mum's attention, they see their part there and they get angry towards it. Or if they see a child who was, getting excited about something because they thought they're going to get a reward and they don't get it, they go, sucked in, because maybe there's times in their lives where they were anticipating something good and they didn't get it. Until they sort of have other parts that sort of kind of lash out at their own parts that they see in others. So I guess what I'm getting at, often we're quite ashamed of our own experiences of the more vulnerable patients. But here, if they give themselves a different emotional experience, if they as they see that part, whatever they're embarrassed about, they did a horrible mistake, they did something wrong, they punched someone, that person broke their arm or something like that, or they got abused. And this time, instead of the typical experience of shame or repulsion towards themselves, they express compassion and achievement to themselves, then that changed the experience. And I'll ask them, what's it like for that part? Can you convey your compassion towards that part? Can you convey the energy of your compassion towards it? What's it like for that part to receive the compassion for you? It feels good. Can you take that in? Very important to do it slowly. It's not like a checklist of questions, it's an experience. What's it like for you to see that part, accept that compassion? It feels good. What's it like for the part that accepting the compassion to see you can transmit that? It feels relaxing. And then that sort of provides a new experience. And there's other questions, for example, the part's working really hard, the anger part. Can you show your appreciation to that part for the effort it's doing and not keeping you angry? If there was a different role that could do, we could guarantee you wouldn't be left alone. What role would it like to do instead? So they're kind of sort of the questions you do as you go deeper into intrapsychic world. And then typically afterwards, you bring them back. Can you ask the parts to pull their energy back from you, and you bring them back to present? You might have a bit of a debrief like we just talked about. So that's a typical session. In terms of the course, it really depends what the goals are. Like someone's acutely anxious or depressed in just one session to do those things. Sometimes people want a deeper understanding of themselves. And to understand, not necessarily mentally ill, but they kind of just notice these particular patterns of interaction with others that's a bit troublesome. In that case, it can go on for years. But it's kind of open-ended, really, because no one ever reaches necessarily full psychological perfection or whatever. And it depends how much time people want to spend on that, and how acute their goals are. So really, it's kind of like, I hear about people 1 or 2 years and those sort of things, but it's not necessarily a set time frame.
Yeah, that was a very good explanation of how would a typical session of IFS look like. My next question is that how would you apply IFS, or what are the disorders, what are the psychiatric disorders in which IFS would be indicated? So what are the indications for IFS?
So really, any mental health problem, I know it's even used in psychosis. I don't know. I don't know if I could say only without medication, but for example, so we have for anxiety, what function is the anxious part serving for? Often presenting for negative feelings, or what? How is the depressed part trying to help? With trauma, for example, you look back at a particular incident where an experience, and how did you feel when that person punched you, for example? There was a part of me felt angry, part of me felt scared, part of that part might still feel scared now, part of me wants to get revenge. Any of those parts interesting to you at the moment, you get to know those parts, and can you continue on the same way we talked before? Anorexia, so I got this man, for example, he's 50, he believes that his mum was subject to medical negligence in a hospital. and they made a decision to give her, withhold fluids from her because they said she's palliative care and she's going to die, and they stopped giving her fluids. And he was very upset by that because he's like, maybe if they kept giving fluids, she might have recovered. He thought she actually was going to recover. So all these parts have been activated. Lots of anger, lots of sadness, lots of self-regret, mistakes, things you might have made or might have changed the outcome. A lot of it goes back to early childhood experiences, communicating the different parts around that. Another example is someone who once with anorexia. So I had this 8, 9, 17-year-old girl and talked to the anorexic part. When did it first come into your life? And she said, I think when she was around 12, that her brother was obese and had diabetes, something like that. And she noticed that people didn't like him, or he wasn't popular, so she wanted to be nice and liked. So the anorexic part came into her life at that time. And when you started the process of sort of communicating and, developing a relationship with the anorexic part, positive relationship seemed to come. I've got to segue a bit. That's a bit different to the classical approach. For example, Maudsley-based family therapy sees anorexia as a villain. You've got to get rid of it. It's an enemy. It's a horrible thing. You've got to externalizes it, but it's got a very negative attitude towards it. But by understanding the function of the anorexia, how it's trying to help, that can change the experience of it. It can be applied to couples therapy. So, for example, if one partner says something that makes the other partner upset, what happens internally for you? What happened? How are your parts activated when he says that? When they work on their parts, because often they'll respond in ways that are trying to protect their parts. They'll get angry, they'll get critical, they'll get defensive, or they might placate and be submissive. Anything to protect that negative feeling, or that negative exile within themselves. But if they can attune to those exiles themselves, then that can change their experience, and that can change the way they react back in the cycle. Family therapy, as I mentioned before, if a parent can understand why that's the parts that are being activated, which cause them to react in a certain way to the child. And you can do IFS within children as well. So really, I think it can really be applied with anything really, really across the whole field within psychiatry and psychology.
So I think it would be appropriate to say that it is more or less, it can be applied to any psychiatric disorder except psychosis.
Well, they do apply it for psychosis, IFS. They do work with psychotic patients. I think the only one that actually they struggle to work, I just didn't want to say they only do that and not use medication. I presume they do use medication as well, but I'm just not sure. But also the one that they say is about brain injury. They find that they just can't access help with people who have brain injury. It doesn't seem to work with those clients, but really otherwise across the board.
Yeah, and I'm not sure whether you'd be able to answer this or not, but I think so. What does the literature say about the response rates of internal family systems therapy, and how is your personal experience about the response rates of internal family systems therapy?
Okay, so there is I believe there's one RCT which looked at people with IFS with rheumatoid arthritis. So they actually found a improvement, the reduction of their symptoms and the depression. I think even their pain, the physical symptoms as well. So it is also, I think it's rated, I can't remember the exact rating, but there's some classification rated level 1 or 2 or something, evidence-based sort of thing. So there is some evidence-based, not nowhere near as much as they definitely call themselves evidence-based based on those, more like a handful of studies, I forgot them off the top of my head, but nowhere near as much as CBT. But CBT is practiced by a lot more people because psychology undergrads, I think they're all in CBT. So there's so many more people doing it, more likely to research it. IFS, I should say, is people usually have done some other type of therapy before it. Then it's more like a postgraduate sort of thing they do. So by nature, there'll be less people with it. But my response rate is, I think, for people who, look, I don't know, it's difficult for me to compare because it's really the only individual type of therapy I've really done. But I think for people, generally, they walk away having more positive emotional experience when they leave work. They generally feel better afterwards. That anecdotally, when I'm lying on this, yes, I do feel more I'm managing my anger better now. Like I feel a lot more control. Another girl, like, I feel she's a lot more able to assert herself and, sort of push back, when she feels pressured. And she's saying her friends have told her she's noticed herself becoming, more assertive. Another guy, like, I guess anecdotally, definitely an improvement. I've got another guy who's got this man I mentioned, this poor guy, like he's got so many um at the end of every session he's feel much better, but he seems to have PTSD and he keeps getting more different intrusive memories each time. And he seems to have so many, like he'll deal with one that goes and a new one comes. So actually just increases medication. He's made a bit of an improvement. I think we were able to around 4.5. Now it's 6. Subtle, but it's taking quite a while. So for his medication. So I mean, look, generally positive. I must admit the people I've been working with in maybe not so much in the severe mental health spectrum. Um, my own personal experience, kind of people sort of depressive. It's kind of a bit slower, but he reports that it's helping each time. I've got another guy with complex trauma. He's been quite a lot of different therapies beforehand. So he generally feels a bit more relaxed after the session, but it doesn't necessarily transmit. But look, between sessions. So I think there's just a handful of people I've got, but generally I kind of feel it's more of a sort of gradual, positive, incremental changes over time.
And is there any application of IFS beyond psychiatric disorders for wellness, for positive psychology?
Yeah, I think so. So I think if we use something, for example, like you have someone who's very high functioning, typically, like often we think high functioning, someone who's CEO of a company, for example, a very high position. I think they've done really well. Now, IFS, you might think of it actually with they're kind of learning. These are very good managers. They learn to keep more vulnerable feelings at bay, for example, and they might be sort of highly driven, make a lot of money, and people really admire them, but they may not be necessarily more attuned to their more vulnerable feelings, and they might struggle with their relationships, with their children, for example, because they're sort of living in a space, or they might have a managerial style which others kind of perceive as a bit being kind of more overly direct, and it may not they might not necessarily convey this sense of harmony. If it's like if you have some consultants who are quite strict and hard, and when you walk into the room, you automatically feel a bit tense, and your heart goes like, well, other people you kind of feel at ease. You just see their face and you immediately feel at ease. So IFS, I think, when is you free up more of their self energy and that their capacity to kind of unblend from these particular parts, I think that improves their quality of life because they can change their perception of what's most important for them, what they're driven towards, how they react in different situations.
Yeah, so what I get from your answer is that yes, it has a great potential for wellness and for people who are or who want to be high achievers and high performers.
Or who already are high achievers, but they're finding somehow they're not fulfilled. Or if we want to be high achievers, I might challenge what their perception of high performance is. Do they actually want to is making a lot of money? Is actually what they really want, or is that something by their parts? But I guess when we talk about people in the public sphere who want psychological help, or mostly psychological, not necessarily psychiatric, but there's a whole variation. People who are schizophrenic, for example, severely depressed, not functioning, bipolar. But then on the other hand, you have people who, for example, find it hard to form relationships. Or you might find people who are kind of find that they're always they find it hard to accept themselves. They're people pleasers, for example. They kind of just find that really frustrating. Or some people kind of find they're getting upset, by different things. And those people might come to therapy and they're functioning well, good enough. They're getting on. They'd never get anywhere near a public health, mental health setting. There's questions about themselves that they have. So from that, I think that would overlap with the wellness industry a bit. They're functioning okay. It's not severe mental health illness, but they want to do better. They kind of feel they're not living there's something not quite right about the way things are going, wanting more fulfillment. And those people IFS can help as well. which I think sort of leans into that sort of longevity frame you've been mentioning.
Yeah. And one question just popped out in my mind while we were conversing, that what would be the application of IFS in personality disorders?
Yeah, so personality disorders, let's say, we'll go through the different ones. So, like, say, borderline personality disorder, which is you kind of have this. I think personality disorders actually have more polarized parts. So the same parts that we all have, but they're more extreme and they're more opposites. And that's the key thing. So a lot of people with this fascinated me. When I was studying for my exam, I was sort of like, I better learn the questions to screen for personality disorders. And you'd have someone who's overtly borderline, but ask them things more like the OCPD ones. Do you find your things need an order? Yes, absolutely. I love to keep the house clean. I love to have things in order. Hang on, you've got the wrong diagnosis. That's OC, just more OPCD, not borderline. But I realize I've actually got this polarity of it, you know, and the part of them that's desperate to be admitted, for example, seeking care, and I've got another part of them that's feeling horribly ashamed that they are seeking care. That's whole situation. They beg, I need admission, and I feel horrible. Oh, I hate asking for admission. So the same parts that we all have, we all, get shy. Sometimes we all want stuff. We all need expression of care. We all have parts that may be embarrassed about it, but these are more amped up because of the experiences I've had of that these more extreme parts have become more extreme to help them get through life. So the application is helping them, get to know their parts, unblend from their parts, understand how they get triggered in sequence, how they're organized, befriend them and help them settle. For narcissism, someone who's got parts that, managerial parts that want performance, want connection, want to be admired by others, because there's more vulnerable parts that, weren't nurtured, weren't accepted, for example, and more parts that, are critical of others because and critical of others kind of protects the more vulnerable parts until that feels more vulnerable. I'm going to talk about schizoid, which is not that well known, but it's a big thing in, I think, a lot of under the classification of called James Masterson. The way he explained it was schizoids, a bit different from DSM, but these people who kind of caught in between, but they don't want to get too close to a relationship, but they don't want to be too distant either. And they're kind of fluctuating a bit all the time. And they might have parts that are, afraid of connection because that's been associated with being appropriated, being made submissive, being made, put down. And other parts which are afraid of isolation, or, being discarded. And you kind of have this polarity between them.
Yeah. So, I recall that this is pretty much in line with the psychoanalytic understanding of the schizoid personality as well, because what we would describe in schizoid is that the person is socially withdrawn, but psychoanalysis says that the social withdrawal is a defense against the schizoid hunger, the desire to get the connection.
Okay. Yeah, that does sound a lot more like, yes. Okay. Yeah, that's good. So that's different to sort of the DSM one, which kind of DSM frames it as that they want to be away from people.
Yeah.
But psychodynamic is great. Okay, that's good to know that, we're on the same page with that. That's right, yes. Another thing I point out is that polarized parts are seen as actually serving they're protecting from the same exile. So, for example, that example, if I get too close, I'm going to feel, humiliated and make me feel bad about myself. What happens? And I make me feel despicable. What happens to despicable people? They feel alone. And the other one, the part that that's afraid of being isolated. What are you afraid of being alone? I'm afraid of being alone. And when there's this exercise called campfire, where you get the polarized parts to be in a campfire and they look at each other. And often the first question, what's it like for them to look at each other? They say, oh, they hate each other. They're not getting along with each other. Then you ask, can they see that they're both trying to serve the same thing, the same goal? And often when they do that, there's this revelation and there's different emotional experience. Oh, wow, that's different. And I feel more at peace there. So I guess that's the one thing I haven't mentioned yet. When you get the polarized part to realize they're actually trying to serve the same function, that can cause a big shift.
Yeah. So as we near the end of the webinar, I would like to ask the last question that you mentioned about Christianity.
Yes.
And from what I gather, you must be a proud Christian. And
Yes.
so, how does internal family systems therapy is how is it similar to the Christian understanding of the mind?
Yeah, so I think this is just my view, so I don't know if I can necessarily generalize it to everyone, but I believe we're also all created with a soul, which have this given like the qualities, given certain qualities, which were good by nature, like, um, which are the things, compassionate, courageous, clarity, and those sort of things. So that's what we're born with. And because we're born with a soul that has these characteristics of God that become built in with it. But then throughout life, because of sin and those sort of things, we develop, and all the defections that are in the world, we develop all these other strategies to try to navigate them things. And these parts, if they go too far, then that can go into sin, etc. things. But if you have this soul that can understand why these different parts are being activated and how for them to do other behaviors apart from those ones, that can sort of create more harmony. So that's how I've kind of made sense of it myself.
Yeah, so I can recall the days when I used to read Bible, and I have studied major religions under the sun, and the first religion I read about was Christianity.
Oh,
And the Old Testament was quite boring for me as a kid, but the New Testament was bang on.
okay. Yes. Okay. And what was it about the New Testament that,
I think I think the values of the New Testament, like
yes,
the forgiveness, and what the Christ says about forgiveness. I think if I have to mention one quality that I like about the New Testament, that is forgiveness.
yes. Yeah, and that's a really beautiful, yeah, quality, yeah, that you mentioned there. That's right. Yes. Yes. So, and I think so theoretically, like when IFS, like if you do sort of unblend from the different parts, that puts you more in a space where, you do that forgiveness. I mean, I think from a Christian perspective that like you do sort of there's a lot of reliance on the grace of God, for those sort of things and those qualities. I guess the way I've kind of harmonized it too, as well as that, we do whatever we can as well from both sides, to free ourselves up to understand ourselves better as well, except prayer and except seeking grace as well, to manage the dilemmas of life.
Yeah, and that is my understanding of the Bible. But what actually I've gathered since these many years is that New Testament is just a confirmation of the Old Testament. And that is what the Jesus says, in New Testament, that uh, he's not negating the Old Testament, but he's adding to the Old Testament.
That's right, completing the law. That's right.
Yeah,
Yes,
completing the law.
that's right. Absolutely. Yeah, that's right. So with the Old Testament, that did that. This is the law. This is what we're meant to be doing, but and it shows us what the right way is, but we can't manage to do the right way on our own. So we fall short. But that Christ provides his grace so that he makes that bridge. So helps us to put you to fill that deficit, fulfill that deficit we have from completing the law on our own. That's right. Yes.
Yeah, but to me, it appeared mutually contradictory when I read the New Testament and the Old Testament. And I thought that what the God is saying in the Old Testament is contradictory to what Jesus is saying in the New Testament. But then I think I have come to this conclusion that this is completion of the law.
But that's a really good conclusion to have, yeah. Because I can definitely see it for others on the external level, that's completely different. But yeah, when it's really good they've been able to see it together as a completion as opposed to something that's contradicting.
Yeah. It was amazing, Dr. Sam, listening to you about internal family systems therapy. And uh, this session will be uploaded on YouTube, and maybe we can have the young psychiatrist looking at this session choose to practice internal family systems therapy, and maybe we can have more practitioners of IFS in future inspired from this session. Thank you very much.
Thank you very much. Your pleasure. Thank you for your enthusiasm, your interest, and developing this to be a resource for psychiatrists and residents everywhere. And it was a very nice discussion. I really enjoyed it. Thank you so much.
Thank you. Bye bye.
Bye bye. Bye bye. Thank you.